Welcome back, everyone. Today, we are diving into the body's ultimate survival mechanism, the sympathetic division of the autonomic nervous system. Think of it as the 911 dispatch center for your body. When you're facing a crisis, this system flips the switch. Dr. Sarah, I know you have the exact specs for the boards, so where does this all kick off?
It kicks off in a very specific neighborhood, Dr. Khan. For those prepping for exams, the key term is thoracolumbar outflow. The preganglionic neuron cell bodies are strictly located in the lateral gray horn of the spinal cord, from segments T1 to L2. If a question asks about the origin of the sympathetic system and you see anything outside that T1 to L2 range, it's a distractor.
T1 to L2, the sweet spot of the spine. But here's the thing. We have sympathetic effects in our eyes and our toes, far away from T1 or L2. Why does this matter clinically? If the origin is so limited, how does the signal get everywhere else? I like to think of the sympathetic trunk as a massive interstate highway, with exit ramps at every level.
That's a perfect analogy. Those preganglionic fibers exit the spinal cord via the anterior roots, join the spinal nerve, and then take the on-ramp, which we call the white rami communicantes, to enter the sympathetic trunk, or the paravertebral ganglia. These trunks run the entire length of the vertebral column, from the neck all the way down to the ganglion impar at the coccyx.
And that is how a signal starting in the chest can end up causing your pupils to dilate or your sweaty palms when you're nervous. Now, Sarah, let's talk high yield. Students always get tripped up on the rami. How do we keep the white and gray rami straight?
Precision is everything here. White rami are the on-ramps. They are myelinated, which is why they look white, and they are only found between T1 and L2. Gray rami are the off-ramps. They are non-myelinated and are found at every single spinal level. Every spinal nerve has a gray ramus to carry postganglionic fibers to the body wall. If you are the doctor of choice for a patient with a nerve injury, you have to know which rami are affected to predict the deficit.
Exactly. Now, let's get clinical. Imagine a 65-year-old man comes into the ER. He's got crushing chest pain, it's spreading to his left arm and jaw. He's pale and he has goose flesh, those tiny bumps on his skin. Dr. Sarah, what is the sympathetic system doing here?
In a myocardial infarction, the body is in a state of extreme stress. The sympathetic system is in overdrive. It causes vasoconstriction of the dermal arterioles, that's why he's pale, and it stimulates the erector pili muscles to contract, which creates that goose flesh effect. On the boards, they might ask which neurotransmitter is responsible for that skin response. For most sympathetic targets, it's norepinephrine, but sweat glands are a classic exception, using acetylcholine.
Why does this matter clinically? Because when you see a patient in shock, those cold, clammy hands and pale skin are visible signs of the sympathetic system trying to shunt blood to the vital organs. It's a literal fight or flight response happening right in front of you. But let's go back to that man's chest pain. Why is he feeling it in his jaw and arm? That's not where the heart is.
That is the concept of referred pain, driven by visceral afferents. These sensory fibers travel backward along the same path as the sympathetic nerves. They enter the spinal cord at the same segments as the somatic nerves from the arm and neck. The brain gets confused and thinks the pain is coming from the T1 dermatome, the inner arm, instead of the heart muscle itself.
It's like a crossed wire in the body's electrical system. Now, let's talk about how the sympathetic system affects the pipes, the blood vessels. We mentioned that cutting these nerves can actually save a limb in some cases, right?
Yes, in severe arterial disease. If we perform a sympathectomy, stripping the sympathetic innervation, it causes the blood vessels to dilate. Without that constant sympathetic squeeze, or tone, the vessels open up, improving collateral circulation. It's a surgical way to override the flight response when it's doing more harm than good.
I love that. It's about balance. The sympathetic system speeds up the heart and opens the airways, bronchodilation, but it also shuts down the unnecessary stuff during a crisis, like digestion. It closes the sphincters and slows down peristalsis. It's all about resource management.
And don't forget the S for sympathetic: stress, survival, and the spinal origin at T1 to L2. Contrast that with the parasympathetic D for digestion, defecation, and the craniosacral origin. For your exams, remember, sympathetics have short preganglionic fibers and long postganglionic fibers because the ganglia are mostly in that paravertebral trunk right next to the spine.
Great point. The ganglia are the staging area right outside the spinal cord. To summarize, the sympathetic division is the thoracolumbar outflow from T1 to L2. It uses the sympathetic trunk to reach every level of the body. Clinically, it's why a heart attack causes pale skin and referred pain, and why shock presents the way it does.
Spot on. Keep your rami straight. White for on at T1 to L2, gray for off at all levels, and you'll be golden for both the clinic and the boards.
Thanks, Dr. Sarah. That's the sympathetic system in a nutshell. We'll see you all in the next episode.